Bismillahirrahmanirrahim. Today, as part of Sepsis Week that we have organized in our hospital, we'll touch the subject of sepsis scoring, which is so very important to start the management of sepsis. I'll start with the historical perspective of sepsis, the realization of importance of sepsis in the medical fraternity. It started in 1991, 30 years ago, when the mortality rate started to rise and the patients started affected by sepsis. The number increased from thousands to millions. So the world bodies all over the world, they started to organize symposiums and seminars on the subject and devised guidelines for the management. In 2004, we got the first guideline, international. Then 2008, then we started the surviving sepsis campaign in 2008. Then famous third international consensus on sepsis management, the sepsis bundles, came out in 2016, and then the hour one update in 2018. Now, sepsis is a major healthcare issue simply because it is affecting now, as I said, millions per year, 1.5 million around the world per year, instead of thousands 30 years ago. And secondly, it puts a lot of economic burden on the economy of every country. And thirdly, most importantly, of course, is the mortality rate. If the patient goes through septic shock, the mortality rate is around 30 to 50%. That is, every second patient will die of sepsis, and 20-30% for sepsis only, which is a very high mortality rate. Therefore, the magnitude of problem, the sepsis, should be equated in priorities in medical fraternity as a case of polytrauma, where you will find all the surgical team and even the hospital administration becoming alert to receive the patient and manage the patient. Similarly, acute MI will also initiate a lot of activity in the hospital, stroke also. Sepsis should be put in the same category as case of polytrauma, case of acute MI, case of acute stroke, because of its huge economic burden that it puts and the high mortality rate. Now, there are key concepts of sepsis, like primary cause of death from infection, especially if not recognized early. That's the most important point of all sepsis guidelines: recognition of early sepsis. Because once you recognize the problem early, you initiate the management early, and your results will be good, the mortality will be lower. And the concept of sepsis scoring is to manage this problem: how to recognize the symptoms and signs of sepsis early on. It is a syndrome which is shaped by pathogen factors and host factors. Of course, it induces organ dysfunction, may be occult, but if you recognize early, you can stop the progress. Unexplained organ dysfunction also, there is underlying sepsis which may not be obvious, the source may not be obvious to you. If there is organ dysfunction, you should suspect the sepsis as the underlying cause. This was discussed by Dr. Osam the other day. The respiratory tract infection takes the higher percentage as a cause of sepsis, followed by urosepsis and abdominal sepsis and skin and soft tissue. Pathogens I will not touch, but gram positive, gram negative, and also fungal, as Dr. Osam said in his presentation, there is fungal sepsis also. And sometimes you will not grow any culture, nothing will grow. This is culture negative sepsis. I discussed this already. The patients being affected in millions, bed occupancy, the cost and economic burden that it puts on the economy of countries, and high mortality rate. Now, definitions were also taken care of by ICU team, but just to revise with you, these are the latest definitions of sepsis and septic shock, and these are the two terms now used as before we had SIRS, then we had sepsis, then we had severe sepsis, then we had septic shock. Now, these are the two terms internationally used and recognized. Sepsis, life-threatening organ dysfunction caused by a dysregulated host response to a new infection. Now, this dysregulated host response, this is the cause of organ dysfunction. The response of the human being, the patient, it starts to damage its own tissues. That's what is the hallmark of sepsis. While in septic shock, it is a subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. As I told you, the mortality rate with sepsis alone is 20 to 30%. With septic shock, with all these phenomena, it's around 50%. Why we need the scoring systems? I said in the earlier slide that detect the sepsis early on with early symptoms. Now this scoring system will predict the organ dysfunction and mortality better than without scoring systems. Now, what are the scoring systems and which one we should apply? Now, over the years, there has been a steady progress in the development of scoring system. Like we had SOFA score, we had Lord's score, and we had quick SOFA score also for situations outside ICU, like in ER, like in the ward. The SOFA score before was the best one because it defined the sepsis in and out of ICU. It could be applied with quick lab tests and could be applied even on bedside. Now, quick SOFA score before, as I said, it was applied before outside even the ICU, and it consists of three parameters: respiratory rate, altered ventilation, and systolic blood pressure. Now, at least if two criteria were present, it will strongly predict that there is likelihood of poor outcome in out of ICU patients with clinical suspicion of sepsis. Any two of these three. The screening prompts. This is a term being used in the UK these days. It means the same as scoring systems, but just a different English word, a different terminology. Now, historically, before the scoring systems evolved, they were using the SIRS phenomena to predict the morbidity and mortality of patients. After that, the quick SOFA score became the main scoring system, and nowadays track and trigger warning score, the MUSE, modified early warning scoring system. This is the latest one, MUSE, MEWS. Now we all know about the systemic inflammatory response syndrome, the SIRS, where the temperature more than 38 or less than 36, heart rate more than 90, so respiratory rate more than 20, white cell count more than 12 or less than 4, and this blood glucose now has been added if more than 7.7 millimoles in a non-diabetic patient, and new altered mental state. Now this is a comparison between SIRS and quick SOFA. I will not go into the detail. Now SIRS is still relevant in the management of sepsis when you cannot apply the scoring system use, which I will discuss now, but the SIRS is still relevant. It is not out of the management. Now this is the MUSE, the modified early warning score. Now you can see here in this chart, this is the score. 0 for normal values, 1, 2, 3, and 1, 2, 3 on both sides for higher values and for lower values. What are the parameters? The same as respiratory rate. If 9 to 14, this is 0 score because it is normal range. If it increases, you increase the score with it also. If it decreases, you also increase the score with it. The second parameter is heart rate. Third is systolic blood pressure. Fourth is temperature. And fifth is level of consciousness. Now, you will put the values regularly in your chart and then you will have a score. If your score is more than 4, your patient is highly critical because it falls in the red category. You can see there the color coding has been given: blue, yellow, orange, and red. In red, 3 to 4 scores, and more than 4, it is the staff nurse in the ward. If he calculates the score as 4 or more, she should immediately call the physician on duty because this patient is going to be critical. Now this is a new term, news. I told you about news, modified early warning system. This is news, a new term being used in the UK. I have the paper. If somebody wants, I can give you the reference for this. This is even a more advanced variety than news, but not yet adopted. The one we will use in the wards, in the ICU, for the monitoring is the news, modified early warning symptom. Score, this one which I just discussed with you. But just to give you an idea, there's another scoring system is developing, which is this one, the national early warning system. This is being used in the UK only. Now historically the scoring has evolved. As I said, first the SIRS were the monitoring criteria, then the QSOFA, then news, and now news is being developed as a new scoring system. But right now in practice is the modified early warning scoring system. Now there are different terminologies that you will come across in the sepsis. This is slide I'm just giving you an idea of the terms being used in sepsis. I have a paper. Dr. Isam sent me a UK paper recently published, which has all the definitions and details of these terminologies. But just to give you an idea that all these terms are being coined these days: the sepsis bundles, and sepsis surviving campaign, septic shock, SIRS, screening prompts, the scoring system, red flag sepsis, amber flag sepsis, all have different meanings in different situations, different categories, different criterias. You can have the details. I have the reference with me. Thank you very much. This was just short presentation about news. The summary of the presentation is that Muse modified early warning, early symptom scoring symptom is the one we will be applying practically, and ideally every staff nurse should have a chart displayed in the ward so that she can categorize the score of sepsis patients.